Hello, it's really nice to welcome you to this podcast where we're going to be talking about our experiences of critically appraised topics. So my name's Kay Stevenson. I'm a consultant physiotherapist and also an honorary professor at the Impact Accelerator unit at Keele University.
And hi everyone, I'm Dr. Ellie Zargam and I'm a Knowledge Mobilisation Research Associate working in the Impact Accelerator also at Keele University. And I'll be chairing this interview with Kay. So Kay, firstly I just want to ask you, what is a CAT and how did CATs start or come about?
Okay, so CAT, as I'll probably call it from here on in, it stands for a critically appraised topic, and it's a process whereby you try to take a question, and that's likely in this case to be clinical questions. You refine that into an answerable question and search for the very best evidence to answer that question. So the CAT methodology, the critically appraised topic methodology, is a way of trying to find the best evidence to generally answer some of those clinical conundrums that we're all facing probably every day in our practice, whether that's clinical practice, whether that's operational management. This process really can be used, across many different areas of practice. And how did it come about? Well, I think I saw a little bit of a gap or an opportunity really to help us utilise this relationship between researchers and clinicians to help understand evidence and utilise it in practice. I just got to kind of thinking that there was lots of good quality research that perhaps we weren't utilising in practice to help our patients get the best outcomes for patients. And the best way I thought of doing that was to bring people around a table to share their experiences, share their knowledge. So we probably started this whole journey back in 2003. And at that time we brought clinicians mainly with an interest in muscle and joint problems. We brought researchers and systematic reviewers, and we started to ask ourselves, where were our clinical challenges? What could we improve practice by in terms of looking for the best evidence to help us? So that's how it started, and our first question was about the management of people with back pain, because we knew in one place we'd got group activities or a group session for people with back pain. In another location we were just doing individual care, and our clinicians wanted to know which was the best option and what was the best evidence, how would that guide us. So that's how we started, and we've been going since then. We've been a continual group since 2003, and I can talk a little bit more about the kind of developments in a little while.
That sounds great. So how does a CAT methodology differ from, say, doing a systematic review?
Yeah, it's a great question, and that's a question we get asked a lot, really. So for us, in my understanding, as a systematic review requires the systematic reviewer to go and look for every single piece of evidence they can find, leave no stone unturned. So looking for published literature, unpublished literature, the grey literature, following up references, reference lists, contacting the experts. So really a really exhaustive process in finding everything there is to know about that particular topic. Whereas a CAT works around a very, very focused question. So the focused question then focuses the search on the research. So you don't end up with everything like you would do in a systematic review, but you end up with the best evidence to answer your specific question. So it really is around the most of the time when we look at intervention type questions, A versus one treatment versus another treatment, we utilise this process called a PICO. So this PICO. And that helps us really refine the thinking and refine our question that we then take to the librarians to do their search. So in answer to your question, what's the difference? Systematic review leaves no stone unturned. It finds everything, and it must look for everything in different languages, not just English publications, in all languages. Whereas a systematic review focuses the search very much around that particular question, around your PICO that you've formulated.
Perfect. So I know you've alluded to it a little bit, but what's the CAT process?
Yeah. I think because we follow a particular process, everybody knows how it all works, and if we follow the process, which most of our CAT groups do now, so we start with this conundrum, so this challenge, whether it's a and people noticing there's variation in practice or differences in practice or differences in outcome. And we come together as a group now of researchers, clinicians, patient partners as well, and we try and refine that challenge into a PICO. So, for example, it might be, people with presenting with osteoarthritis with the knee, and people want to know what is the best way to treat patients. So we might say, well, actually, we refine the population. We're interested in adults over the age of 45 with knee pain. The intervention might be a particular type of exercise or a group exercise. The C in that little PICO could be a comparator, which is maybe usual care or sitting on a waiting list. And then the O of the PICO is the outcome. So are you interested in pain, function, return to work? So that PICO, population, intervention, comparator and outcome, really focuses your attention on getting that clinical question. Then the clinical question goes off to the librarians, they search the evidence, and they generally send back to us a list of abstracts with titles, and we do a first sift. So we look through those questions and look through those abstracts to say, do they answer our question, yes or no? So we do a first sift. Those that we think answer our question, we then look in more detail to assess the quality of those studies. And that critical appraisal, which is a great skill for us all to kind of keep refreshed, we utilise in the main the Critically Appraised Skills and the CASP programme, so the Critically Appraised Skills programme. And on that CASP website, there's all sorts of appraisal tools for different types of research. And they're a great way of people being able to discuss the quality of evidence together. And then once we've reviewed the quality, we then come up with a clinical bottom line. So it's the answer to that question we started with. So this whole process takes you from the clinical challenge, refining a question around a PICO, searching the literature, reviewing the quality of that literature, then coming up with the clinical bottom line, and then you think, so what next? What do we do? And that what do we do next might depend on what answer you get. So let's say, for example, you get great quality evidence that means you need to change practice. You then link with your clinical and operational colleagues to change practice very rapidly, very quickly. If there's no evidence at all, then the researchers hear that, and that's a gap in the evidence, so that might be of interest to them to take forwards. If there's not great quality evidence, you might want to think, well, how in my service would I improve what we offer? So you might, often people do audits of practice, they might collect patient stories, they might collect clinician stories. So what evidence have you got to say that what you're doing is of value to your populations that you manage?
That's really interesting. It sounds like there's a systematic process in place though. And I know you said patients and clinicians can get involved, but anyone else that can get involved in the process?
Yeah, so around our table, I mean, you know, Ellie, you're an expert in knowledge mobilisation. Generally the literature says that it takes about 17 years, doesn't it, for clinical practice to change based on evidence. And this is a process that really speeds that up. So we found through our Critically Appraised Topic process, we can change practice really, really quickly. But it does depend on, getting the right people around the table. So clinicians, it may be the operational managers who need to be around the table with you, our patient partners, our research colleagues, our people who are interested in methodology, and our librarians. So, those people generally are the people who come around our table, because we want to be able to undertake the process and then make rapid changes in practice, or undertake audits, or help researchers kind of think about what their next step is for the research question to get that answered.
Yeah, sounds great. So where are CATs currently active?
So our CAT groups are active. We've got quite a few now that are operational around the country. So we've got our Keele CAT group, we've got a couple in South Staffordshire, we've got a couple over in Shropshire and Oswestry, we've got a CAT group active over in Leeds. So there are lots of groups who are following this same methodology, again to kind of engage clinicians, researchers and patients in finding the best evidence to answer practical, challenging questions.
So can you highlight some of the benefits of CATs?
Yeah, definitely. So I think one of the things that we've learned is that when we get people around a table together, they start to learn together and understand each other's context. So researchers get a really good sense of what's happening in the NHS, and what the NHS context is looking and feeling like right now, and some of the challenges that clinicians, managers and patients are facing. And the same is true in reverse. So clinicians, managers and patients get a real understanding of how challenging it is to undertake research, high quality research, to get the funding and to kind of make sure that that research programme is executed to the highest quality. So you gain that real understanding. Of course, the patient partners, they bring that lived experience of what it feels like to live with a condition and seek healthcare, and they have been so amazing at helping us kind of think about the CAT process and what we needed to do differently. So the benefits are you all learn together, you develop skills together. So I would say that the critical appraisal skills of our staff have really improved and supported our staff. We've had rapid changes in clinical pathways because of the CAT, so we've stopped doing some things, we found evidence of harm, we've reintroduced things that needed more attention, we've done things differently because of CATs. So it really does help you reflect the evidence in your local pathways of care, which has been fantastic. I think it gives clinicians, patients and researchers this relationship where they can start to understand each other's world, but then contribute to each other's world. Because of the CAT group, we regularly invite researchers in to do presentations for us in our clinical settings and vice versa. So it's just created a really nice working understanding between people. Our patient partners, in terms of the benefits of having them alongside us, they've really encouraged us to think about how we translate the messages into kind of meaningful messages. So they encourage us to write a lay summary, which has been a great addition, but they've also helped us think about how we share our CATs in a broader context, social media, LinkedIn, vlogs, blogs. So they've really helped us think about spreading the message of CATs.
Again, so I know you've alluded to this a little bit, but can you share some examples of CATs where they've had some impact, say in clinical practice, in research and, like you said, with patients?
Yeah, so if I give you a couple of examples, one was where we stopped doing something. So we, many people will know the sort of, they'll have heard the phrase tennis elbow, and we offered different sorts of care for people with tennis elbow in our services, and clinicians wanted to know, were there any benefits or risks to undertaking corticosteroid injections. So we refined the PICO, we searched for the evidence, and we found a high quality study. It was an Australian study that suggested if we injected patients with corticosteroid in its kind of chronic state, when it's been around for a long time, there was greater incidence of harm. And so we stopped doing those injections for patients over a particular time point because we felt it would be more harmful. So that was something we could do literally within a couple of weeks. We could stop doing that. One of the critically appraised topics where we found no evidence, which resulted in a trial, one of our physios wanted to know about a particular type of exercises that were quite trendy at the time. They were called stabilisation exercises, so they were getting a lot of attention. But one of the physios said, I'd like to know what the evidence is behind utilising these exercises. We searched we made the PICO, we searched the evidence, and we couldn't find any. We couldn't find any evidence at all. So then the researchers here at Keele went, that would be a brilliant idea for a trial. So they then undertook the trial and gave us the answer to the question we were looking for. The nice thing about that, the added benefit, was that the clinicians who started to ask those questions were involved in the research advisory group, so became involved in the research process as well. So that was really good. One of our patient partners wanted to ask a question about shoulder exercises, so she was really keen to find out if the advice from physios around giving shoulder exercises was robust and evidence-based. So we worked through the process of the CAT with her, and she said she learned a lot from how rigorous and robust the process was. So she was really reassured at the end to kind of find out that exercises for shoulder pain were beneficial. So, whichever the outcome, whether there's positive findings, it helps you change practice, where you find potentially quality, the evidence isn't of high quality, it encourages you in your service to think how you measure that quality yourselves. And where there's no evidence, we link with the researchers, and we also kind of put these into, there are websites where you can say there are unanswered questions. So I think the James Lind Alliance is one where you can put unanswered questions, so funders can go and look at that. Lots of positives for clinicians, patients, the pathway, people getting the best evidence, and really creates that sort of relationship working and that deeper understanding of each other's worlds.
So in your experience, what do you think ensures the success of a CAT group?
Yeah, okay. So I think that we found over time, if you've got a consistent lead, so if there's someone who's there leading the group over a period of time, that seems to give the group some stability, some sustainability. So I've led our Keel CAT group probably since 2003. So, everybody kind of knows it's going to be me that's kind of taking that forwards and helping everybody coalesce around the CAT process. So definitely having a clinical lead, definitely having your academics in the room. We often come across methodologies that we're not sure about, we've not heard about before, and the academics are brilliant at being able to help us understand. And often the academics know what's been published, so they've kind of said, I think there's something, you'll find something in this. So often that they know what's about, because that's their bread and butter, isn't it? That's their expertise. The librarian is crucial, absolutely crucial, because they do the part of the process that we did try it once, but we were terrible at it. So the fact that the librarians can rigorously search the databases for us and produce this kind of list of kind of research articles that answers our question is brilliant. So our librarians, and I have to say our librarians have been so supportive, irrespective of where our cats have popped up. They've been absolutely brilliant. So definitely academic support, definitely patient partners, definitely that's key. Definitely your leadership and keeping it consistent. And I would say from the NHS side, we've had a lot of generosity in terms of CPD time. So a lot of our operational leads see this as CPD time, which it absolutely is. It's looking at the evidence to improve care. So that's been a huge assist, if you like, to the whole process.
Great. So I know we've highlighted some of the benefits, but have you faced any challenges over the time you've run CAT?
Yeah, I think probably one of the biggest challenges has been about trying to find funding especially for our patient partners. That's not been an easy thing to try and because they are absolutely crucial in this process. But we've had to be a bit creative about how we try to gain funding for them. Our researchers are funded through their kind of academic work, and our clinicians, basically that's their CPD time. So they're, as long as our managers are supportive of that, which they are, that seems to work. So that's been one challenge. I think in some areas people have struggled to find an academic with the area of interest, so that's been a bit of a challenge. So, but we've gained some confidence and got a bit further afield sometimes for that. So not thinking we might find it locally, but being able to be a bit further afield. And maybe technology, Teams has helped with that, hasn't it, since COVID? So those have primarily, I think, been the challenge. And sometimes we just have to be, pragmatic. We know that in busy acute organisations, when winter pressures hit, sometimes we have to press pause on the CAT groups and then start them again in the springtime. So we are hugely responsive to how the NHS context is looking and have to be really cognizant of that.
I know you identified this as a challenge, but how have you secured funding or secured support?
Yeah, I think what we've done, we offer a couple of training sessions. We call it CAT in a day. So we generally run it every 12 months. So we run through the whole process that I've just described in a day, where we bring people together, we introduce them to the process, we help them formulate a PICO question, and then we do some critical appraisal, but then we also talk about the impacts and the potential changes they might make. So we seek funding and people pay for that, and we have a little bit added on there to help us ensure we can secure our patients attending with us. So that's the mechanism we've used over time. And the CAT in a day, we do that, I say, generally occurs in the winter time. We do it each year, and it's really, really well attended. But we've also started to offer bespoke courses because teams have contacted us to say, can we do this as a team together, and would you come to our location? So we've done that on several occasions now, where we're like cats on tour. So we go and deliver this to a group of clinicians and researchers in their specific location, which again has worked really, really well.
That sounds great. So I know you mentioned you've done a cat in a day, but is there any other training available, and where can you find more information?
Yeah, so if you go onto Google and if you just put EBP at Keele, so that's EBP at Keele, then the evidence into practice groups generally comes on about the second or third on the list. So all our resources are on there. So all our CAT questions are on there, all the resources, all the paperwork, everything that might help you. There's blogs on there about CATs, because we encourage people, once they've done one, is to share. They write it up, but they also share it as well. So that's on there. You can also contact me, so I can give you my email address at the end, and I can put you in touch with any local groups that might be active in your area, or invite you to the training, or at least send you the information about the training when we know it's coming up. We'd be very happy to do that. We're also quite, I think, if people are interested in the process, we're happy to come and give a talk. If people want to hear more about it, very happy to do that, just to stimulate people's thinking around the process. Because to me, it's like there's a win-win for everybody. Patients are getting best care, their pathways are reviewed, clinicians and operational managers are asking questions, we're linking with the best evidence, patients are involved. There's nothing not to like about this process.
That sounds great. I know you mentioned the Evidence into Practice website, but how else have you shared results of CATs?
I think we were encouraged to think about, for the first few years we were just writing them down, we were just kind of doing a Word document, and then we've started to think a little bit more creatively. So our Word document is now kind of, we apply the accessibility rules to it, so hopefully it's more accessible to people with any reading challenges, so that's great. We also have done infographics, so it's more pictorial, it's more visual, so that appeals to people. We've also done videos, so where the clinician who's leading the CAT tells you a little bit about their experience, and it kind of lifts it off the page really, because the written form will give you all the information, and it's great, it's very, very detailed. But actually what you get listening to the vlogs is the clinician's passion about why they wanted to do it, what drives them in terms of improving patient care. And without a doubt, every single one of them want to make patient experience better. And that's what drives them to do it. So you will hear the passion and you'll hear the enthusiasm coming out in the vlogs. We've done presentations to international and national audiences. We took the CAT process over to a group of academics and researchers in New Zealand who are really keen to get it up and running, so they're starting their own CAT journey, and it's because it appeals, I think. Oftentimes research can feel a little bit scary, but if you approach it from, we're doing this to improve our patient care, that feels a more comfortable place to start for some people, and you introduce the research that way, and I think people get much more engaged. You asked me previously about benefits. We've had a couple of folks who've been on our CAT groups, CAT in a Days, that have then gone on to do PhDs. It's stimulated their interest so much in the research that they wanted to kind of carry on in a more, to do it into a more greater depth, which is brilliant, absolutely brilliant.
Sounds fantastic. So what do you think the future of CATs is?
I think there's a couple of things I'd mention. I think we all appreciate, everybody who kind of comes to the CAT groups appreciates the learning we share with each other. So I can't see that changing. This relationship's kind of catching up with people, hearing the challenges from a research and clinical perspective, and trying to drive improvement through that process. I think we've managed to get our patients to the table. I think other groups are still in that process of working out how they can do it. So hopefully in time we'll see more patients participating in our CAT groups. I think probably one of the biggest shifts is where AI might be able to help us. So up until recently, we've had our patient partners writing a lay summary for us, And what we started to do now is say, well, if we ask AI to write a summary that is in, reading age of 8 or 9, and then ask our patient partners to check that over, that relationship seems to work really well between the AI. So I think AI is going to be more helpful in perhaps reviewing some of the evidence for us, but we are doing it longhand and we are doing it in AI. So we're trying to compare, checking that we're not seeing hallucinations in the AI. So I think that our understanding of how AI might help us in cats will kind of be the next phase of their development. But I think fundamentally this relationship between understanding each other's worlds is where it really has its greatest value, those kind of interconnections and understanding each other's worlds. But I think AI probably is going to be the next thing we need to grapple with and get an understanding of.
Brilliant. Thank you so much, Kay, for your time and your expertise. I've really enjoyed speaking to you, and I hope you found this resource useful.
Thank you.